Hello, everyone. Happy Thursday. Very excited for today's VMR. I am joined in the co-discussing seat by VMR legend Gia, who I think this is a celebration of many things, but unfortunately for us in VMR, we'll be seeing less and less of her as she embarks on her intern year, having successfully matched in a very tough application season. And so I think it's nothing better than to bid you farewell right before the finish line with discussing together. And for those of you who maybe not familiar, Gia has been part of the team for almost a year now, having been emphatically introduced to VMR with a series of very intriguing cases. We miss your cases, but we're very excited, Gia, for the ones that will inevitably come in the future. I'll pass the mic to you to say hello, and then I will go ahead and introduce our case presenter.
Yeah, hi audience. I'm Jia from China, and as Dr. Rabin said, I will become a PGY1 at Baltimore, and I'm very excited for the coming intern year. And I'm also want to express my gratefulness to the CP solvers because I think outside of like medical knowledge, I receive a lot of support and encountered a lot of passionate and kind friends here, and I really enjoy my time here.
Well, the feeling is mutual, my friend. The feeling is mutual. I'd also love to welcome Pranay. Pranay, do you want to tell folks a little bit about yourself?
Yeah, sure. So I'm a big fan of CP solvers, first of all, and thank you for letting me present the case. I'm Pranay from India, and I matched in internal medicine in New Jersey this cycle. And I really love internal medicine at the core. And apart from medicine, I am an avid cyclist, and I love some bit of finance. And recently, I've started cooking some Indian food. So
Nice.
very happy to be here.
Amazing. Well, massive congratulations on your match. That's very, I know it was a very tough season, so very happy for you. Congratulations to you both for matching. Ah, wow, what a really cool series of hobbies from cycling to cooking. That's really amazing. Where in India are you, Pranay?
So I am from the west part of India,
I
Gujarat,
see. I see.
and yeah, I did my medical school from VJ Medical College, Ahmedabad.
I see. Wonderful.
Yeah.
And how do you manage cycling and the heat? Because I know that is something that comes up a lot. How does that
Yeah,
happen?
it's kind of a problem, but I've been cycling for 3 to 4 years now, and I think I'm quite habitual to cycling in this weather,
Yeah,
so
you're just used
not a
to it, huh?
problem for me. Yeah.
You may get cold when you try to reproduce your cycling adventures here.
Right.
That's wonderful. And so, I'm curious. I've seen you on CP Solvers many times, but I don't think I've bumped into you presenting a case before. Is this your first case presentation, or have you done it before?
No. It's my first time presenting the case on CP servers.
Amazing. And what got you? I know you've been part of the community for a while. What got you to decide to jump in and present a case?
So I've been part of the VMR for like 3 to 4 months. I think I started in December when I came across a link on the web, and I joined the first VMR report, and I was just absolutely amazed by the amount of knowledge that I got from the VMR community. Like it was just like I'm in the hospital taking round with such brilliant minds, and I thought this is a great opportunity for me. And actually I worked in a cardiac hospital for 8 to 9 months, so I had some patient records with me, so I thought that this is a great platform to share the case.
Wonderful. Well, thank you so much for doing so. I think it's the ultimate gift where you get to benefit from showcasing your skills and practicing them, and we get to benefit from learning together. So I'm really grateful that you jumped in. And yeah, I think we've got Ethan who's scribing today, and Parisa is doing teaching points. And so let's get ready to jump in. You can start whenever
Sure.
you're.
Yeah. So we have a case of 48-year-old gentleman who presented with complaints of breathlessness and an episode of loss of consciousness. And for the history of present illness, he had some complaints of breathlessness with labored breathing for 1 to 2 days, and he complained of dizziness for few hours, and it was followed by loss of consciousness. The episode was witnessed by his wife, who said that the episode was brief and she did not notice any abnormal jerking motion of the body. His wife said that he gained complete consciousness after few seconds and he was fully awake and alert, and he did not have any other complaints. For review of systems, was negative for chest pain, fever, abdominal pain, nausea, vomiting, headache, diarrhea, urinary incontinence, and body ache. And this is the end of first aliquot.
I can tell you've been on VMR for a while. What an amazing aliquot. Gee, I can see you're very deep in thought. I'm really curious if you can share with us where your mind is starting, because I think there's a lot of learning. You have the dyspnea and then you have the LOC. Where do you think you're starting your thinking? Are you starting by in the world of dyspnea, or are you starting in the world of LOC?
Yeah, I'm just thinking like, are these two symptoms like connected together? Because when we see this case from the time course, seems the dyspnea, the shortness of breath, came first. But if we consider which is more severe and which should we like pay special attention, because that is very dangerous, I would say it's loss of consciousness. And yeah, I think I think if I encounter this case, probably I would check the oxygen saturation first, and also do the series of workup of loss of consciousness to make sure all these severe situations can be avoided.
I think that's absolutely superb. I just want to pause to say I see that our dear friend Amanda is back in VMR after a very, very long time working very hard. Welcome back, Amanda. It's so nice to see you here. Gia, I think you said it so well. You said that the more severe symptom is that this patient literally had no blood flow. And that is something to take very seriously. And I agree with you. I think we should start our thinking around the loss of consciousness and then use dyspnea as a clue. And so I'm curious, if you were just to remove yourself from this case and practice your reflex DDX for transient loss of consciousness, how do you think of the causes of LOC, transient LOC?
I would think from two major perspectives, from the cardiac etiology and also from the neural etiology. Like for when thinking about the cardiac etiology, I would think of anything like make the heart function lower, and so the patients may have a transient low pressure, which lead to the loss of consciousness, lead to the syncope. And also, I would think another major perspective is from the neurology, like stroke, like seizure, and also I remember we have several things that can help us to rule out other etiology, like the myths. I remember like infectious etiology, like the substances, like and metabolic etiologies. Yeah. I see Dr. Rabih already typed like, this in our chat box. Yeah.
Dr. Rabih's like the 6 S's. I think your analysis, Gia, is really, really advanced. When somebody loses consciousness, what we are trying to understand is the problem in the brain intrinsic cause, or is it extrinsic? Meaning something happened outside the brain that profoundly affected the brain. And the most important intrinsic cause of a transient loss of consciousness is a seizure. Why? Because of all the devastating intracranial things that can happen. The most common to cause a global issue, loss of consciousness, and to be transient is a seizure. A stroke is unlikely to be both transient or global. You may say, well, a TIA can be transient, but a TIA is very unusual to cause a global dysfunction of the brain unless it's in a very specific location. That's why seizure gets the leading consideration of the intrinsic causes. But you're right that stroke deserves consideration. The extrinsic causes are mainly syncope, and the other important thing is sugar or hypoglycemia. So you might really quickly check a sugar in this patient, and I think it just goes to show you how we really have a hard time confidently distinguishing seizure from syncope in many instances. And those instances are only difficult when there are no accompanying clues. The patient just had loss of consciousness and that's it. But here, the profound accompanying clue of shortness of breath is a very strong suggestion that it is an extrinsic issue rather than a seizure. And so I think it goes to show you that when you have dyspnea plus LOC, you really, really prioritize a cardiac cause. And even if you tackled it from the other direction, Gia, which is you said, this patient has dyspnea, is it heart, lung, or other? The presence of subsequent loss of consciousness really prioritizes syncope, i.e. a cardiac issue. And so I think the overlap of dyspnea and loss of consciousness is really, really suggestive of a cardiac problem. And as you said, that cardiac problem has to be very severe. I'm curious, are you confident in a cardiac cause, or are you open to other things at this time? What do you think? Where is your head at in terms of, are you still open to lung issues? Are you open to seizure, or do you have confidence that this will be a heart issue?
Yeah, I would agree with you that we should think of the combination of these syndromes. And I also want to know more about the patient's past medical histories that help me to become more confident that it is a cardiac issue.
I agree. I think that the stakes are too high for you to make that assumption. But I think that the only overlap that I can think of dyspnea and episodic loss of consciousness that isn't cardiac is anemia. I think the probability of this being cardiac is very, very high. And so I want to be very targeted in my assessment. We'll have a conversation later about what kinds of cardiac issues show up like this. But I will tell you, most of them you will able to hear on your stethoscope, like aortic stenosis, as an example. It's very important to be ready for a cardiac cause that you do not hear on your stethoscope. And those cardiac causes are primarily pulmonary hypertension, either acute, like PE, or chronic, and hypertrophic obstructive cardiomyopathy. So here's where I'm at authentically. I'm, like you, very worried about this patient. I want to make sure that we don't lock in to a specific narrow area, but the combination of syncope and dyspnea is very suggestive of a very small set of cardiac issues. And those small set are obstructive cardiac issues. And this will hopefully become more clear as we get more data. And I'm already telling you the most important test right now for this patient, I think, will be what his cardiac auscultation is like. Is there going to be music or is there not? And I think that's really telling. But let's first follow your advice and just make sure that there aren't any other clues. But when the time comes on the exam, let's listen very carefully to that CV exam. I think it'll be very powerful. All right, Pranay, tell us more, please.
Yeah, sure. For his past medical history, he is a known case of diabetes mellitus type 2 and dyslipidemia, and he was on regular medication. 1 week ago, he had complaint of epigastric discomfort for a few days, for which he consulted to the nearby hospital, and where his ECG was done, which was suggestive of anterior wall myocardial infarction. He was given loading dose of clopidogrel, aspirin, rosuvastatin, and he was referred for angiography. And upon arrival to the hospital, he was immediately taken to the cath lab, where angiography revealed that he had thrombus in proximal LAD, and primary angioplasty was performed using drug-eluting stent. The post-procedural course was uncomplicated, and after that, he was discharged 2 days with appropriate medication. And the medications were dual antiplatelet therapy, ticagrelor and aspirin, rosuvastatin, torsemide, metoprolol, telmisartan, metformin, and glimepiride. Uh, the patient did not have any history of smoking, alcohol consumption, or tobacco chewing. His family history was insignificant, and he did not have any history of allergies. And this is end of aliquot number 2.
Thank you, Ethan, for keeping up. I think
Am I going too fast or?
maybe a little bit. Yeah, I think
Oh, okay.
it's hard
Yeah.
when you're presenting the first time to not
Yeah.
speak very fastly, but I think you can try to keep an eye on the scribe and just match with
Yeah.
their
Sure. So his family history was insignificant, and his history was not positive for tobacco chewing, alcohol consumption, or smoking, and he did not have any allergies.
Oh, thank you so much, Brian. That's perfect. Yeah, you were cautious about getting rich medical history, and I think your caution has been productive. You got some very rich medical history. How did it change your thinking?
Yeah, and I think this medical history just make me more tend to the cardiac perspectives, because I'm very worried, is this like post surgery like complications, or is there any like worse in this patient's heart functions? And I really want to like do more workup into this patient's heart, like echo, like ECG, yeah, such things.
Yes, I completely agree. I think you said something really good, which is that you're now really worried that this is a complication of the procedure, and essentially you're entering a specific schema, which is really the complications of acute coronary syndrome. But before we talk about the complications of acute coronary syndrome, it's really important, as you said, to talk about the complications of the procedure of getting a cardiac cath. So what is your current knowledge base about what complications of the cardiac catheterization can occur?
I may think about like any injury to the cardiac walls, and then lead to perfusion, and then lead to tamponade, which is maybe very can lead to this syncope and dyspnea. Yeah. And also, I think like post procedure complication may also include some arrhythmia, yeah, such things, and also infection could be also a consideration.
Excellent. So you're thinking about what can happen when the catheter is in the heart. Can it poke through the coronary arteries, causing pericardial issues? Can it irritate the heart and cause arrhythmia? And now I want you to go back and think about what complications can happen when the cardiologist pokes the skin and goes into the vessel. What can you think of that can happen when at the access site, either in the radial or the femoral? Have you heard of these things that can happen where the needle first goes in?
I'm not sure like which like point you want to like mention, but I may think of like something like hematoma,
Yeah,
like bleeding. Yeah, but yeah, very cute things.
I can see why you would think, but wait, why is that relevant here? You're right, because if you make a hematoma here or in the femoral, it shouldn't cause this syndrome, but the complication of femoral access that can cause this syndrome is that the patient has a hematoma in the retroperitoneum, which can cause a lot of blood loss. And so the patient can drop their hemoglobin 5, 6, 7, 8 points, and that can cause shortness of breath and syncope. So it's always really important to ask how the cardiac cath was performed and what site was accessed. It is very unusual to develop an access-related complication 1 week after an MI. Very unusual. The one complication related to the cardiac cath that can happen in a delayed manner is cholesterol emboli syndrome. That usually happens a week after. That syndrome is not necessarily compatible with the presentation that we're seeing right now. And so I think you're right that the access site is probably not the focus of our attention. But if this were happening 1 hour after, you have to make sure the patient doesn't have an RP hematoma by hemoglobin. So I think our focus is probably going to be on complications of ACS. And so I love your thinking about getting an EKG, getting an echo, and really thinking about the heart now front and center. This is a good time to practice what we know. So I'm curious, what do you have you learned in your experience about things that the EKG or the echo might show you?
You mean the EKG or echo that may show like something related to the ACS complications?
Yeah, what have you learned about ACS complications?
I would first think of any valves dysfunction, and also like the cardiac walls dysfunction, and also like there is any perfusion around the heart. Yeah, such things. And also yeah, I think the echo can also help us can see any thrombosis. Yeah.
Excellent. Yeah, absolutely superb. I think that we divide the complications of acute coronary syndrome into electrical complications that will be seen on the EKG that you like, or mechanical complications, which will be seen on the echo that you order. The electrical complications are either bradyarrhythmias, referring to AV block, or ventricular arrhythmias, VT or VF. There are many, many mechanical complications, which we can review later. What is your instinct? Are you thinking his presentation is more suggestive of an electrical complication, or are you thinking his presentation is more compatible with a mechanical complication? What do you think?
I probably tend to the mechanical complications, because I think this patient's dyspnea has like lasted for 1 day, and also the patient actually spontaneously recovered from this loss of consciousness episode. So I may tend to the vote for the mechanic etiologies, because I think if it is caused by the electronic etiology, I think it is hardly to be spontaneously recovered, and like hardly to be sustained for like 1 day more. Yeah.
My advice to everybody is wherever Gia is voting, you should probably vote in that direction as well. And that's what I'm going to do. Excellent. Now you're seeing, Gia, why it's so important that the stethoscope and a very, very, sometimes I listen to a patient's heart and I know I'm not going to hear anything. So I listen and I'm already thinking about the next patient, or I'm not listening very carefully. For this patient, I would listen more closely than I've probably ever listened, because of the idea that mechanical complications are so important to think about here. So the music that the heart makes is going to be very, very important. But we have to make sure we don't eliminate mechanical causes because there is no murmur auscultated. There are some conditions that, and if you remember, maybe 1 month ago, we had a presentation of acute mitral regurgitation. As an example, acute mitral regurgitation, you think, oh, I'm going to hear a murmur, but you're not. That's because in acute mitral regurgitation, there is rapid equilibration of the pressure. So much so that the murmur only happens for 1 second. You don't hear it. And so here, I think I'm really intrigued to see how hemodynamically compromised the patient is. But from a diagnostic perspective, I think the most productive tests will be the stethoscope test first, and then of course the EKG and the echo. Alrighty, Pranay, tell us more. We're very intrigued.
Yeah. So going on his vitals, his temperature was normal. Heart rate was 108 per minute. Blood pressure was 94/68 millimeters of mercury. His oxygen saturation was 96% on room air, and his random blood sugar was 98, and the respiration rate was 24 per minute. On physical examination, he looked in mild distress, but he was well oriented to time, place, and person, and he had an obese body habitus. His HENT examination was normal. Cardiovascular examination showed tachycardia, normal S1, S2, no murmurs, rubs or gallops, and no jugular venous distension. Pulmonary examination was significant for tachypnea and bilateral lower lobe crackles. Abdomen was soft, non-distended, non-tender, with normal bowel sounds. Neurological examination was within normal limits, and his skin and extremity examination was also normal. And while he came to the hospital, at that time his ECG was suggestive of Q waves in anterior leads, which was similar to his previous presentation. And while he was being admitted and we were doing the workup, we noted multiple VPCs on the monitor with intermittent runs of non-sustained ventricular tachycardia. So what test would you like to order?
Very intriguing, Pranay. Thank you so much. So yeah, Gia, what are you thinking so far?
Yeah, yeah, I'm actually kind of surprised that we have like no significant sound finding in the CV examinations. But I agree with what you mentioned before, that sometimes some change in the valves may not easy to listen to. So I still believe at least bedside echo is very important to help us rule out any mechanical changes. And for the like tachycardia, especially the NSVT, I'm actually currently not so sure. Is it like does it can indicate any like remarkable things, or is it just a appearance of the underlying etiologies? Yeah, but I would definitely check ECG to see what his rhythm look like.
Excellent. Excellent. Yeah, I think that's superb. I'm curious, we just to start our analysis with and a really interesting clue. What is your understanding and significance of seeing Q waves in the anterior distribution? What is the value of Q waves for you, Gia?
I think the Q waves may make me think of like the patient's previous MI. Yeah.
Yeah. And so I think the question for us to analyze is, what does the presence of Q waves tell us about the status of the previous MI? And so a question for you to think about is, does everyone with the previous MI develop Q waves? What do you think? What's your instinct?
I'm actually not so sure about it, but I think the answer is probably no, because yeah, but I don't like understand why so why there is some Q waves in some patients and why not. Sometimes I may think of like is this related to the time course? Yeah, that's kind of one thought. Yeah.
Like I said, whatever Gia says, you should all just listen. Exactly right. So most of the complications of acute coronary syndrome occur in patients who have a delayed time to reperfusion. And there are many proxies that can help you understand how long the patient has had the ischemia for. Of course, the history, if the patient has had chest pain for 1 week, that can help you. And then, of course, the exam, if the patient is in cardiogenic shock, it's very unlikely that they just had their MI. And then there are some clues on the EKG, and the most important clue is Q waves, which indicate that the patient has had a completed myocardial infarction. There are clues in the cardiac cath lab as well, and those clues are seeing that the actual thrombus has now been becomes harder and more difficult to extract. So I think that we should be even more concerned that this patient is suffering consequences of ACS, because we now know for sure, with high degree of confidence, that the patient had a large amount of ischemic time before he was reperfused. And that's what the Q waves tell you. So it really opens the door for you to be really worried about those complications. So that's when you went into electrical complications and you talked about how when you saw PVCs, you were worried. You weren't sure what their significance is, but you were worried that they may represent something more serious. In all comers, PVCs just indicate that there is an irritated myocardium. And the question is it irritated because of a chronic issue, or is it irritated because of a dynamic issue? And in the patient who's having PVCs, especially if they're PVCs of the same morphology, they look the same, then you worry that those PVCs are a herald to ventricular tachycardia, monomorphic ventricular tachycardia. And VT might be a thing to think about here for two reasons. The first is the patient had a completed MI and now has a scar tissue that is arrhythmogenic, or the patient has ongoing ischemia and he has either rethrombosis or restenosis, and that ongoing ischemia is actually causing a polymorphic VT. So what I would really look for on this EKG is to try to understand if those PVCs are of the same morphology or different morphology. And the key question is, do we, in addition to getting an echo, do we have to do a repeat cardiac catheterization? And I think ventricular arrhythmias in a patient with coronary disease is often a trigger to do a repeat ischemic evaluation. The urge to do an ischemic evaluation would be even higher if the patient had polymorphic ventricular tachycardia, which is much more compatible with ongoing ischemia rather than monomorphic disease. So I think, Gia, now, sorry, just 1 second, I'll go. The question now is, does the patient have a mechanical issue that is stethoscope negative? Or does the patient have an electrical issue that is either the result of a scar or the result of ongoing ischemia? And so I think the active questions now are, what does the echo look like? And should we do a repeat cardiac catheterization? And I think the troponin will help us for sure.
Mm-hmm.
If the echo is negative, I think that further reinforces the need to do a cardiac cath. And if the patient has an overt arrhythmia, especially if it is polymorphic ventricular tachycardia, then a repeat cath is in order. So I think mechanical, coronary, and electrical issues are all in play here. And it's going to be really important to get it right because the patient is verging on the edge of cardiogenic shock with his vital signs. I think I'm most worried right now about coronary disease, ongoing coronary disease, because the patient doesn't seem to have evidence of jugular venous distension that you might expect in a patient with a mechanical complication. But we all know that even amongst experts, accurate assessment of JBP is not always reliable. So that's where I think I'm at. I'm curious if you have any other thoughts to add in there before we hear the next aliquot from Pranay.
No, I don't have other thoughts. I just really love how you interpret the PVC according to their shape, and that's very helpful to with to our like clinical management.
All righty, Pranay, tell us more. We're very intrigued.
Yeah, absolutely. So on laboratory examination, his CBC counts were normal, and comprehensive metabolic panel were sent, which were also normal with one abnormality, potassium of 3.2 milliequilibrium per liter. All other tests were normal. Troponin was mildly elevated, and his HbA1c was 7%. COAC profile was also normal, and echocardiography was done, which was suggestive of LVEF of 25% with regional wall motion abnormalities in LAD territory. And there were no valvular abnormalities, and IVC was 18 mm with more than 50% collapse during inspiration. No pericardial effusion was noted. While we were sending the labs and monitoring the patient, he had another episode of monomorphic VT that progressed to VF, and it was managed with DC shock. And he was started on IV amiodarone bolus and followed by IV amiodarone treatment. And that's the end of the fourth episode.
Wow, Pranay, this is really, really intriguing. I think we haven't had this scenario, honestly, on VMR. So I'm so excited that you brought this case for us to learn. Just to help to make sure I don't talk too much, can you remind me how many total aliquots do you have?
Oh, after this, there is the final diagnosis. So this is the last.
Okay, so we can really spend some time here. Thank you so much, Pranay.
Yeah,
I'm very
and
grateful.
just to
Yeah.
add another thing,
Yes.
the echo was similar to the previous echo, which
Excellent.
was done 1 week ago during cardiac catheterization. Yeah.
Excellent. Thank you so much. Yeah, I think as Ravi just said, every incoming intern will be very grateful for you bringing this case because I think it teaches us a lot. So Gia, where is your head at now with the we have a lot of management thinking to do. I'm curious, where is your head at with the diagnostic aspects of this case? Oh,
Yeah, yeah. I think currently the echo actually help us rule out a lot of worries, at least about the valves, and also the EF is similar to what the patient had 1 week ago. So I think currently the echo actually help us rule out the mechanical perspective things that we worried before. And also, I always think it is very interesting that the patient's progress or the changes in the disease can help give us more information because this patient have an episode of arrhythmia and received a temporary pacemaker. So I'm like more I currently I tend to the idea you mentioned before that it is an arrhythmia complicated by the ACS. Yeah, but I'm not sure in this case should we still go with cardiac cath or how we should manage this patient.
excellent analysis. I couldn't agree more with you. Let's first finish the diagnostic conversation, and then you and I will ask you to try to practice how you would manage this patient. But let's just talk diagnosis. So I'm going to show you all a visual that it illustrates exactly what Gio was talking about, which is a very simplistic model of the acute complications of ACS. And as you may remember, Gia said, I just want an EKG and echo right away. And you're seeing an EKG can help you in two ways. It can help you by showing evidence of ischemia, which would make you wonder if the patient has stent-related issues or has another evident episode of ACS. So EKG positive, either recurrence suggestive of ischemia or a rhythm issue, VT or bradycardia, as we talked about. So because we're so fixated on this category, I think it's important to talk about the echo. And here the echo does show that the patient has a massive drop in contractility. The EF is very low. And the question before us is, how good is the echo at excluding mechanical complications of acute coronary syndrome? And I think it's important to think about that because so many arrhythmic issues are the result of active cardiac issues, either active cardiac ischemia or an active mechanical issue. So if you have a really bad active mechanical issue, you can go into an arrhythmia and that's not your only problem. So we need to spend a minute in our minds thinking, before I lock in on VT, is there an active driver for that VT? And Gia was just talking about, is there an active ischemic driver, which is important, and we'll talk about that. But I'll just share with you that the echo is not perfect at excluding the mechanical complications of ACS, which are essentially LV free wall rupture, ischemic mitral regurgitation, and a VSD. I think what helps exonerate those things and makes them much less likely is the lack of elevated filling pressures. All of those conditions would be associated with elevated filling pressures. And here the patient is not hypoxemic and the IVC is not large and is collapsible. And so I think you can move away from mechanical complications of ACS, not because they're not seen, but because the expected consequence of high filling pressures is not seen on the echo. You'll read of many cases a free wall rupture that requires a TEE or even a cardiac MRI. You'll read many cases of ischemic mitral regurgitation that requires a TTE, and the same is true of VSD. But what you will find in almost all those cases is elevated filling pressures, i.e. a dilated IVC, right atrial hypertension. And so I think we can move away from mechanical complications and really start to focus on what the rhythm suggests. And here we see the patient has monomorphic VT. And so I think that the question about monomorphic VT and its relationship to ongoing ischemia is debatable. There are some cardiologists who I've worked with who are like, yeah, polymorphic VT is more indicative of ischemia, but I want to take another look to make sure the stent isn't clogged. So polymorphic VT mandates a repeat ischemic eval. Monomorphic VT allows you to ascribe the VT to the scar that the patient has and does not mandate a repeat ischemic eval, but different cardiologists have different thresholds about when to look. And if you think about it, if you have personally put in a stent in a patient and they're having VT, you might feel obligated to take a look so as to not cause any harm. So that's where I'd be thinking about. I'd be thinking about the very likely possibility that this patient had a delayed reperfusion, has myocardial scar, and has monomorphic VT. I think that's the most likely scenario. There's maybe a 0.1% chance that the patient has ongoing ischemia triggering monomorphic VT. It's very rare, but it's possible. So I think I would be comfortable without an ischemic evaluation, but I'm not the one who puts stents in people. And so Gia, I'm really curious what you think about the management. So have you ever seen a patient with VT before?
Maybe not.
Yeah, that will change for sure. What do you know
Yeah.
about the management of ventricular tachycardia?
For sure it is very dangerous, and we need to do the probably the advanced life support these things, but yeah, that's what I know now. Yeah.
I think anytime that you have ventricular tachycardia, you want to try to classify it into monomorphic and polymorphic, and then try to classify it, is it stable and unstable? And if the patient is unstable, you immediately shock them. If they are stable, you have some time. In stable ventricular tachycardia, antiarrhythmics are the mainstay of treatment, and amiodarone is our go-to medication. The only downside of amiodarone is it is so effective sometimes that it can make it hard for the electrophysiology team to subsequently do an ablation, because the amio works so well and lasts so long and has a very long half-life that you try to ablate the patient and you cannot induce their VT again in the EP lab, so you don't know where it came from. The only time I haven't used amiodarone is when the patient is going to go to the cath lab and to do an ablation very quickly. And the only other time I've used other medications is when there's a concern for ischemic ventricular tachycardia, in which there's some hint that lidocaine may be a better medication than amiodarone, in large part because of its short duration of action and the ability for electrophysiology folks to subsequently ablate the arrhythmia. So I think amio, unless you have your EP team saying, no, we want to ablate this patient, give them something else. And unless you're worried about ongoing ischemic VT, where you might prioritize the use of IV lidocaine. But this patient was unstable, so he was shocked. And I think the availability and familiarity with amiodarone is often pushes it to be our default medication. Any questions about any of that?
No, probably we can let Prina to give us the final information.
That sounds great. All right, Prina, tell us what happened.
Yeah, great discussion. So the hospital course for this patient was just after we gave the DC shock. After a few hours, he again developed monomorphic VT, and it was also followed by VFib. And we again had to give him DC shock. And between these episodes, he continuously had NSVT and sometimes VPC. So the cardiologist finally made the diagnosis of electrical storm post myocardial infarction. And it was so relatable with the patient because whenever he tried to move or do anything like any kind of activity and even moved a little bit, he immediately had this episode of VT. So that was the final diagnosis. And if you want me, I can go on from how did we manage, and if you want some discussion, I can also do.
Yeah, no, I think it's really, we can maybe pause for 1 second to talk
Yeah.
about VT storm. VT storm is the equivalent of status epilepticus for the heart. It requires aggressive attempts to control the ventricular tachycardia and can really, really escalate to many things, including multiple antiarrhythmics, intubation with sedation with propofol, and ultimately even a sympathectomy to remove the sympathetic tone for the patient. So it's a very, very serious and very dreaded complication that has to be treated just like we've learned to treat status epilepticus, very aggressive, very quick, and sometimes even requires multiple medications and even a surgical procedure to remove the sympathetic tone on the heart. So yeah, no, please tell us how you all thought of that and what decisions you all made.
So for this patient, he continuously kept developing a ventricular tachycardia, and he continuously kept going into VFib. So we consulted the EPs, and cardiologist also suggested that he should be put into sedation. And even after that, he had some episodes of monomorphic VT, and we started, and amiodarone was already going on, and he was also started on beta blocker. But even after that, he had some problems with that. So left stellate ganglion blockade was also performed, and his condition was eventually stabilized. And after some time, he was taken to the EP lab, and the focus ablation was done. And in between this period, TPI was also done, pacemaker implantation temporary. And after the focus ablation was done, AICD was also placed for this patient, and he was successfully discharged after some days on beta blockers, amiodarone, and all other medications. So
Oh.
takeaway point for me was that the patient continuously kept developing VT, and it was like the patient was in cardiogenic shock. But if we were to start him on any inotropes, he might not have survived at that time. So in my hospital after this patient, I saw another patient who had similar type of presentation, and unfortunately that patient did not survive due to electrical storm. So the management takes precedence over diagnosis in this type of scenario, and it was a wonderful case to learn.
Yeah, and you brought that case in such a amazing way. You know, I think, Pranay, what you decided to do today was to present the 4 aliquots of bread and butter common conditions. And I'm really glad that you did not go through that very quickly to focus on the rare scenario of VT storm. And I really, really appreciate that you gave us the chance to think about overlap of dyspnea and LOC, ACS complications, electrical versus mechanical, and then reflect on VT storm, which is a really important condition. And I think it is unbelievable that your patient survived, because it requires such delicate decisions about avoiding inotropes, intubation, sedation, stellate ganglion block. Those are very, very advanced technical things. So that is remarkable medical care, and I really congratulate you for it. And I congratulate you for sharing your story in such a way that allowed us to learn a lot. I'm curious, what was your biggest takeaway in taking care of the patient? What was the experience like for you?
So after this case, I really learned about cardiology, like how it requires acute management and the complete diagnosis at that moment. And I also learned a lot about electrical storm. So most commonly electrical storm developed due to structural heart disease, electrical abnormalities, or after ischemia. And for management, we have to be very quick. So there are 3 main things that we have to look for in management. First, we have to decrease the sympathetic activity, because it happens because of overdrive of sympathetic nervous system. So we have to put the patient on beta blocker, and we also have to balance it with the heart failure. So in this case, the patient also was in heart failure. So it was kind of difficult to manage this case. And we had to perform the left stellate ganglion blockade because even after all this medication, he was still going into VFib. So it was done, and he was taken to the EP after stabilization, and where focus ablation was done. So electrical storm basically develops because we have arrhythmogenic focus and heightened sympathetic activity. So it is kind of like taking the gasoline to the fire, and you have the storm. So
That's a
yeah.
absolutely great analogy. I really admire your enthusiasm. You really have the biggest smile on your face as you talk about this case. It's very, very cool to see. Gia, you came and you discussed such a scary acute case in such a public way. I'm really curious, how did it feel? How do you feel now?
I just want to say a big thanks to Prina to bring this amazing case, because I think this is actually what I will encounter in my intern year. And yeah, I really learned a lot from the case, like how to analyze the case and how to deal with this like sudden and urgent situations.
Yeah, I think, yeah, your analysis was so shrewd and wise from the very beginning. And I think you were very, very confident as you went through, and you were really talking through things in a very eloquent manner. And then at the same time, you were very honest about like not being sure about things like the Q waves. I'm not sure, but ultimately you had enough knowledge to know all of it. And I'm really glad we got to go through this journey together. And I hope I receive a message from you in the next year when you see a patient like this in real life and you're like, oh, I was more prepared. I'm really looking forward to that because I know it'll very, very likely happen very soon. So thank you. Alrighty, I see we've accumulated a lot of teaching points. Parisa, the mic is yours.
Thank you so much, Pranay. You started really strong. Your first case was amazing. And Gia, it was a phenomenal discussion. We learned a lot. We have started with a patient who presented with dyspnea and episodic loss of consciousness. We learned that when we are facing two symptoms, it's better to choose the symptom with shorter differential diagnosis and start from there. We learned for approaching transient loss of consciousness, we need to think about it from two angles: intrinsic causes of issue inside the brain, including seizure, or extrinsic causes, including syncope or hypoglycemia, sugar. We learned that a stroke is probably unlikely in this case because it is unlikely to be transient and global simultaneously. We learned that to differentiate between seizure and syncope, we need to address the accompanying problem in the context. For example, in this case, we have shortness of breath, which was guiding us through extrinsic causes of transient loss of consciousness. When we are having dyspnea plus loss of consciousness, the cardiac causes are we need to prioritize cardiac causes, including specifically obstructive cardiac causes. We also need to think about anemia. If we want to use auscultation for differentiation, for example, in aortic stenosis, we will hear something, but for the causes including pulmonary hypertension or maybe left ventricular hypertrophy, we were not able to capture it by auscultation. We also learned that three main mechanisms of syncope are orthostatic hypotension, reflex syncope, and cardiac syncope. We learned also about the complication of cardiac catheterization, which could have acute presentation. For example, in the context of femoral access, we might have retroperitoneal hematoma, which is showing itself with the drop hemoglobin. We also might have delayed presentation like cholesterol emboli. We learned that for finding ACS complication, we have some equipment like auscultation. We also have EKG, which is helping us to capture electronic issue, and echo for finding mechanical problem. Electronic cause of ACS complication, including bradycardy, AV block, ventricular VTAC, and ventricular fibrillation. In the echo, echo will helping us to find when having a feeling pressure problem, we are able to capture it by echocardiography. We also learned that acute MR might not present with VMR because of the rapid pressure equilibration. We learned that delayed perfusion time could present on the EKG with Q waves. which is when somebody have a previous MI who might have Q waves on the EKG, but it's not necessary all the time. If the sorry, I forgot how to talk. When the when we have complete blockage and we have a thrombus, which is hard and difficult to extract, probably Q waves will happen. But if the patient went to the cath lab very fast and quick, probably we do not have a Q waves. And when we have ventricular tachycardia, they could be monomorphic, which is happening in the context of the MI and scar. The scar, it could be arrhythmogenic. It could be also polymorphic VTAC, which is showing us ongoing ischemia is happening in the heart, and repeat ischemic evaluation is mandatory in these cases. We learned that for VTAC management, we need to classifying into mono and poly. And when the patient is stable, we are using anti-arrhythmogenic drug, including amiodarone. Amiodarone is a really good drug because it is effective and it has a long half-life, which is making it harder for the EP team for doing the ablation. If we are our suspicion is so high for ongoing ischemic VTAC, we could use lidocaine in that case. If the patient is unstable, we need to use shock. Our differential diagnosis in here was electronic storm post-MI, which is a status epilepticus of the heart. Most commonly is happening in the ischemia context, and the management is so complicated. We need to use multiple anti-arrhythmogenic medication. We need to sedate the patient, intubate him under propofol. We need to decrease symptomatic activity, which is the main crux of the pathophysiology. We could do it with beta blocker and sympathectomy. If the patient is in cardiac shock or heart failure, we need to make the balance between everything. Thank you so much for this amazing session.
That was absolutely amazing. I'm sorry that you forgot to talk, but I think you were talking very, very eloquently. That was awesome, Farisa. It's really been very cool to watch your growth doing teaching points. I still remember your first session and your hesitancy doing it, and now you're like not even flustered, even when you have a little snafu in the middle and you just cruise through it, which is awesome. Really well done. Big thank you to Pranay. A big thank you to Ethan, who has become a scribing master. And a big thank you to G. I hope you guys had fun, and I'm excited to see you all hopefully throughout the week. Bye.